Now we're going to discuss urinary tract infections. So in general, urinary tract infections encompass numerous syndromes, and these include urethritis, cystitis, prostatitis, and pyelonephritis. And the disease severity is proportional to the host resistance, such as the host immune system, as well as the organism's virulence. And the common etiologic agents that cause urinary tract infections are our normal flora, especially our intestinal flora. Urethritis is an infection of the urethra, and the symptoms include dysuria, which is painful or difficulty urinating, and is similar to your typical lower urinary tract infection symptoms, so possibly some lower abdominal cramping. It is a very, very common infection, and it can sometimes be associated with sexually transmitted diseases because you can have some similar symptoms with some abdominal tenderness, cramping, and painful. Cystitis is an infection of the bladder, and the symptoms include the painful and difficulty in urinating, a feeling of urgency to urinate, having to urinate very, very often, so an increased frequency of urination, tenderness and pain in the abdominal area, as well as urine cloudiness. And you can actually see bloody urine, bright red urine with lots of red blood cells in it. Cystitis is usually a localized infection, and you do not usually see a fever along with a bladder infection. Acute urethral syndrome is primarily a syndrome that you would see in young sexually active women. These individuals will experience dysuria, or that burning during urination, a feeling of urgency to urinate, having to urinate very often, and usually yield less than 10 to the 5th CFUs, or colony forming units, per mil of bacteria on culture. Usually this syndrome is concomitant or goes along with pyuria, where you're going to see lots of leukocytes, 8 or more leukocytes per cubic millimeter in an uncentrifuged urine. Pyelonephritis is an inflammation of the kidney, parenchyma, and pelvis, and the symptoms are fever, flank pain, which is lower back pain, a frequency to urinate, an urgency to urinate, painful and difficulty in urination, and some systemic signs can include vomiting, diarrhea, chills, and increased heart rate, as well as lower abdominal pain. 40% of patients that have acute pyelonephritis are bacteremic, so the resident flora of the urethra, since the opening of the urethra is right next to our skin, we have some skin flora there. So you're going to expect to see some coagulase negative staphylococcus, including our Staphylococcus saprophyticus, as well as our Staphylococcus epidermidis, the Viridans streptococci, some of your non-hemolytic streptococci species, lactobacillus, your diphtheroids or your Corynebacterium species, your non-pathogenic Neisseria such as Neisseria mucosa, Neisseria sicca, anaerobic cocci, your Propionibacterium species, another anaerobe, your anaerobic gram-negative rods such as Bacteroides, as well as some commensal Mycoplasma species. Your typical Uropathogens, pathogens that tend to cause urinary tract infections, are your gram-negative bacteria such as Escherichia coli, as well as other enteric gram-negative rods, and your gram-positive bacteria, especially Enterococcus and Staphylococcus saprophyticus. So other etiologic agents. So community-acquired urinary tract infections are caused by E. coli, Klebsiella, some of the other Enterobacteriaceae members such as Proteus, as well as Staphylococcus. Urinary tract infections that tend to recur, happen over and over again, are usually caused by uropathogenic E. coli, and there are strains of E. coli that have been shown to have a predilection for the urinary tract and be very commonly involved in recurrent urinary tract infections. Also Proteus, Pseudomonas, Klebsiella, and Enterobacter. Hospital-acquired urinary tract infections are commonly caused by E. coli, Klebsiella, Proteus mirabilis, Staphylococci, other Enterobacteriaceae members, Pseudomonas aeruginosa, and your Enterococci. Some much less common etiologic agents that may cause urinary tract infections, but these are not not isolated from the urine very often. These would be Acinetobacter, Alcaligenes, other Pseudomonas species than Pseudomonas aeruginosa, Citrobacter. Now, very, very rare causes of urinary tract infections include Mycobacteria, Chlamydia trachomatis, Ureaplasma ureolyticum, Campylobacter, Haemophilus influenzae, Leptospira, some Corynebacterium species, as well as Salmonella species. So virulence mechanisms of our etiologic agents of urinary tract infections might be adhesins, having the ability to adhere to the mucosal epithelial cells along the urinary tract, mannose receptors, lipopolysaccharide, capsules, and hemolysins. So how do organisms gain entry into the urinary tract in order to cause an infection? Well, they can get in an ascending fashion where they come in from the outside and in through the urethra. So females have a higher incidence of urinary tract infection, and this is due to the fact that the female urethra is much shorter, and this allows these organisms that are outside the body on the skin to gain entry a bit easier. You can also get an ascending urinary tract infection through catheterization. So straight catheterization would cause a urinary tract infection in 1% of the straight catheter cases. An indwelling catheter, so someone that's in a hospital and can't get out of bed, has a catheter into the bladder to collect urine. These individuals, if that catheter stays in the bladder for 3 to 4 days, they have a 100% chance they will get a urinary tract infection. Another route of entry into the urinary tract is hematogenous. So an organism that is in the bloodstream can get into any anatomical site in the body. So an individual that has a bacteremia can get any type of infection, including a urinary tract infection. The factors that are going to contribute to disease are the virulence of the organism, the inoculum size, how much bacteria gets into the urinary tract, as well as adequate host defense responses. So, how good is the host's immune system? Some host factors that would contribute to a urinary tract infection would be obstruction. If someone has an obstruction in the urethra, this is going to prevent that urine from flushing out of the body. So that flushing action of the urine actually allows the body to keep that area clean. So if you have an obstruction and you're not flushing urine out, then bacteria that might be there would be allowed to attach and colonize. Individuals with diabetes mellitus are at higher risk for urinary tract infections, the elderly, as well as female adults. Females have a much higher incidence of urinary tract infections than males do. And there is something called recurrent urinary tract infections, where certain individuals have urinary tract infections all the time, like once a month, once every couple of months, and usually this is due to. So some urinary tract infection facts. The prevalence of a urinary tract infection is both age and gender dependent. So in individuals that are less than 1 year of age, urinary tract infections are more common among males. However, bacteria in the urine, or bacteriuria, in females between the ages of 5 to 14 is 1 to 2%. So as we age, the prevalence of urinary tract infections becomes more common in females. Females over 10%, the incidence is 10%. In elderly women, it's 10 to 20%. And women between the years of 20 and 40 who have previously had a urinary tract infection, 50% of these individuals will get another urinary tract infection within 1 year. So some of the factors in women that gives them a higher risk for urinary tract infections. So risk factors include sexual activity, anatomical and hormonal changes, as well as pregnancy. So as many as 20% of all hospitalized patients that receive short-term catheterization will develop a urinary tract infection. And remember, if that catheter stays in the bladder for 3 to 4 days, there's a 100% chance of getting a urinary tract infection. Urinary tract infections are the most common nosocomial infection in the United States. So there's a lot of people in the hospital that have bladder catheters. And like we said, if they sit there, if that catheter's in there for more than 3 days, they will get a urinary tract infection. They didn't come in with a urinary tract infection, so it becomes a nosocomial infection. Infection in the urinary tract is the most frequent source of bacteremia. So remember, bacteria anywhere in the body can get into the bloodstream and cause a bacteremia. For specimen collection, it's very important to prevent contamination by your normal flora. So any vaginal, perineal, and urethral flora, you need to make sure that doesn't get into the urine. So in healthy individuals, we collect what's called a clean catch midstream urine. So in a clean catch midstream urine, the area around the urethra is cleaned with a moist towelette. That's usually a sterile wipe that's given to you. And then you would start to urinate in midstream. Once some urine has been removed so that you get rid of some of that bacteria that might be on the very end of the urethra, then you start collecting it in your sterile container. Also, you can get urine specimens from a straight catheterization. So this will be not as contaminated, but you can introduce organisms into the bladder from the end of the urethra. The sample that is completely contamination free is a suprapubic bladder aspiration, or what's called a bladder tap. So a bladder tap is when the pubic area is cleaned with iodine, and then a needle is inserted into the bladder and you collect urine that way. So you're not going to get any of the skin contaminants, especially if you wash the skin properly. You're not going to get any of those normal urethral flora. You can also get urine from an indwelling catheter, so hospitalized individuals that have an indwelling catheter to collect urine in a bag. So catheterization is done using a Foley catheter, where you have a tube inserted up into the bladder, and then once it's there, this balloon is inflated to keep that tube in place. And then as an individual collects urine, the urine goes in. So when doing a urine culture, the first thing that you need to do, of course, is look at the urine, look at the color, is it turbid or not, and then what you want to do is mix that urine. You really want to mix the urine up, give it a swirl. You don't want to shake the container, you don't want it to be a foamy mess and risk it leaking all over, but you really want to give that container a nice swirl. We always inoculate plates using a calibrated loop. And for urines, there are two different calibrated loops. There's the 0.01 milliliter or the 0.001 milliliter. So the 1 microliter or the 0.001 milliliter calibrated loop, those are the same. 0.001 mil or 1 microliter. We have our larger loop, the 0.01 milliliter, which is equal to 10 microliters. So the smaller loop, the 1 microliter loop or the 0.001 milliliter loop, is used for your typical clean catch midstream urines that are the more common urine specimen. We only use the larger loop, that 10 microliter loop, when culturing a urine from a suprapubic bladder aspiration. Because a bladder tap is completely sterile, you want to be able to find if there is any bacteria that might be causing an infection, even if it's there in low numbers. So you want to use a larger loop to inoculate a larger sample. So how do we inoculate a urine? We inoculate a urine differently than we inoculate any other specimen. And the reason is you need to quantify the organisms. So instead of doing your typical 3-quadrant or 4-quadrant streak for isolation, what you do is you take your calibrated loop, you take the loop and make a vertical line down the very middle of the plate, and then you go back and forth starting from the top of that plate across in a perpendicular fashion. So let's look at the next slide. So you go across that vertical inoculum back and forth, back and forth, back and forth from one end of the plate all the way down to the other end of the plate. We inoculate in this fashion both a 5% sheep blood agar plate and a McConkey agar plate. So those are the two standard media that you would use to inoculate a urine specimen. But keep in mind, some labs do things a little differently. So some labs will include also a Columbia agar CNA or a PEA agar plate. So remember, a Columbia agar is the opposite of our McConkey agar. McConkey agar is going to select for gram-negatives. Our Columbia agar is going to select for gram-positives. So some labs will do sheep blood agar, McConkey agar, and Columbia agar. But at the very least, all urines are inoculated onto sheep blood and McConkey agar plates. So what is typical used in a clinical lab? In the clinical setting, you're always trying to do things in the most cost-effective way. So what's commonly used are blood McConkey biplates, where you have blood, 5% sheep blood agar on one side of the plate and McConkey agar on the other side of the plate. Here in this slide, you can also see a biplate of 5% sheep blood agar and chrome agar. Chrome agar is an agar that allows the organism to make a color, and you can actually tell which organism it is by what color the colony it is. That's why it's called chrome color agar. So chrome agar is expensive, so not all labs use chrome agar. So even if a lab is using a blood McConkey biplate, it's inoculated the same way. So if you look at the blood chrome agar plate there on the right, that's how your blood McConkey agar plate would be inoculated. You would still make a vertical line down the middle of that half of the plate and then go across all the way down the plate. So our chrome agar, it allows for rapid detection and differentiation of your urinary tract pathogens. So you can see what each organism would look like. So E. coli is red, Klebsiella is blue, Enterococcus is a turquoisey blue color, Proteus is brown and has a halo around it. So your organisms have a very distinct color on chrome agar to allow you to very quickly see what urinary pathogen might be causing an infection. After you inoculate the appropriate media that is used in your laboratory, those cultures are incubated overnight at a 35 to 37 degree incubator. Urines are usually incubated in the ambient air incubator. There are some uropathogens that would require a full 24 hours of incubation. There are also culture systems out there, Bactericult, Dip Slide, and UriCheck, that some labs may use. So here is a picture of a dip slide, and on the dip slide it's a little paddle, and the paddle, each side of the paddle has a different media. So you might have one type of media on one side and a different type of media on the other side. You also have a sterile plastic vial. So what you can do is you could put your urine in the sterile vial and just dip your paddle into the urine, and that is going to inoculate the media on the front and the back of that dip slide. So here's what these dip slides tend to look like. These are also typically used in to look at water contamination in an environment. And here you could see some molds and some yeast growing on dip slides. So for our urines, we're going to talk about how to interpret these cultures. So interpretation of a urine culture depends on the type of urine specimen that was submitted as well as the clinical history of the patient. So interpreting a urine culture can be very difficult because a lot of our clean catch midstream specimens are not actually clean catch, nor are they midstream. A lot of individuals are given a sterile cup, they squat down or stand up and immediately urinate into the cup, cap it, and call it a day and submit your urine. So that wouldn't be considered a clean catch midstream. So these types of urines are contaminated with a lot of your normal urethral and skin flora. So it's up to you to determine which organisms on that urine culture are normal flora that you would see at the end of the urethra and the skin, or which ones might be a pathogen causing a urinary tract infection. So for a clean catch specimen, normally you would see less than 10,000 organisms per mil. It would be considered contaminated if there were three or more organisms, and there wasn't one organism that seemed to predominate on the plate. The culture would be interpreted as having a urinary tract infection if for a male specimen there are greater than 10,000 per mil organisms. If it's a female, it would be considered a UTI if there's greater than 100,000 per mil. The more specimens of urine, the higher the probability of identifying a urinary tract infection. So if you culture 3 urines from the same patient collected at 3 different times during the day, you would have a 95% probability of diagnosing a urinary tract infection. With 2 specimens, you have a 90% probability, and with 1 specimen, you have an 80% probability. So for our numbers, how would you know that there was less than 10,000? So remember, for a clean catch specimen, we use our 1 microliter calibrated loop, or our 0.001 mil. So if you have 9 colonies of a specific organism on a plate, if you multiply that by 1,000, because we have a 0.001 milliliter loop, then 9 times 1,000 would be 9,000. So the number of colonies, your colony forming unit, or CFU, you multiply by 1,000 if the 1 microliter loop were used, and then that's how you would interpret. So a normal specimen, if you had 9 colonies on the plate, you would say, oh, that's normal. There's no infection there. There's less than 10,000 organisms per mil. However, if you had 12 colonies of one organism and 15 colonies of another organism and 20 colonies of another organism and 4 colonies of another organism, then that's considered contamination. You have 3 or more different organisms on the plate, and not one of them is predominating. So for example, if you had a plate in one specific organism, there were 200 colonies on the plate, but there were 20 colonies of another organism and 5 colonies of another organism, since there's one organism that's highly predominating and there's greater than 100,000 per mil of that one organism, you would want to go after that predominating organism. So here's a nice urine interpretation chart, and you should know this chart for your quiz and for the final exam. So you have, if you see no growth or less than 5 colonies, which would indicate 5,000 organisms per mil, you would do nothing and your report would be no growth. If you had less than 10 colonies each of 3 or more colony types, again, you wouldn't do anything. You would say less than 10,000 colonies per mil or CFUs per mil, 3 or more organisms isolated, probable collection contamination. And what you report out is going to vary slightly from laboratory to laboratory. Okay, if you observe greater than 10 colonies each of 3 or more colony types, again, you don't do anything and you write down greater than 10,000 colonies per mil, 3 or more organisms isolated, please resubmit. So there may be something going on there, but there's so many organisms on the plate, you really can't figure anything out without a resubmitted nice clean catch sample. If you observe one predominant organism where that organism is at or near or possibly greater than 100 colonies, which would be greater than 100,000 colonies per mil, with a few smaller numbers of some other colony types, you would quantify and work up only that predominant organism. So once you work up that predominant organism, you would report out the predominant organism. What is it? And what's the susceptibility for it? You would then add in a comment, small numbers of other organisms present. Please resubmit. If only one colony type is seen, so you have a pure culture, and it is greater than 5 colonies of a pure culture, you would quantify and work up that organism and report that out. Because it is a pure culture, it's less indicative of a contamination from skin, and it's maybe indicative of an early urinary tract infection. To interpret a catheterized specimen, normal would be less than 1,000 organisms per mil. So if you use the 1 microliter plate, you can see 1 organism on it, and that would be normal. It would be considered contamination if you had 3 or more organisms with no predominating isolate, and it would be considered a urinary tract infection if you had greater than 10,000 per mil. So if you had greater than 10 colonies of a specific organism, it would suggest a urinary tract infection. If you have greater than 1,000 per mil, but not greater than 10,000, you would need to repeat that cathetered culture. For a suprapubic aspirate or a bladder tap, now this shouldn't have any contaminants here, so the numbers are different. Greater than 10 to the 2 CFUs per mil of any number of organisms needs a complete workup. So that's very different than the other two scenarios. So greater than 10 to the 2 CFUs per mil. So basically, if you have even one organism on the plate, you're going to need to work it up. So in an infant bladder tap, if you have a gram-negative rod, any number, you would have to work that up, and it would be suggestive of a urinary tract infection. If you have a gram-positive cocci, greater than 1 to 2,000 would be suggestive of a urinary tract infection. So if you just had one colony on the plate of a gram-positive cocci, let's say a Staphylococcus epidermidis, it may not be indicative of a urinary tract infection. But if you had 2 or 3 of a gram-positive cocci, then it would suggest a urinary tract infection only for a bladder tap sample. So some of the variations of these interpretation. If you have a pure culture of Staphylococcus aureus, regardless of the number of colonies on the plate, you then have to work it up and do an antimicrobial susceptibility on it. If you have yeast on the plate, and yeast has a very characteristic morphology, it's usually a white colony and it has this little spider veiny look at the edges of it. So it looks like there's these little spider veins coming off of it. If you see yeast, you don't usually work it up, but you report that there was yeast present. However, if there was a pure yeast culture, so you had a culture and the entire culture was yeast, then you would work it up. All urines in each isolate on that plate should be quantified or enumerated, and that's why we inoculate urines in that particular fashion by making the vertical streak and then going across side by side all the way down. So for example, if you had 3 different organisms present, you would have to quantify each one. So isolate 1 had 10 to the 3 CFUs per mil. Isolate 2, 10 to the 4 CFUs per mil. Any organism that's greater than 10 to the 4 colony forming units or colonies on the plate per mil should be further described. So you should do a quick gram stain on it, put it in the Vitec or microscan, and get a susceptibility, because that might be the organism that's causing an infection. So if you have any questions on urines, you can shoot me an email. You will be working up urines in the laboratory. So there is another method for inoculating urines on the plate where you do this circular inoculation method. So you could try both of those methods. Cindy will be showing you both in the laboratory.